Ethical Perspectives on the News is produced by the Interreligious Council of Linn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good morning and welcome to Ethical Perspectives on the News. My name is Bill Farrell. I'm a small business owner, a home builder, and a sustainability consultant, and this morning we'll be acting as your moderator. Recently, the United States Supreme Court made a historic ruling on the Patient Protection and Affordable Care Act. This ruling had been long awaited and was closely watched by many as we, as a country, struggle to deal with the ever-increasing costs of health care and the issues related to health care availability. This morning, we will try to dig into the recent ruling and what impacts that it will likely have on our lives. As we begin this discussion, I would like to welcome to our show our panelists. Todd Pettis, who is a professor at the University of Iowa College of Law. Peter Damiano, who is the director of the Public Policy Center at the University of Iowa. And Ben Lang, who is a candidate for the Iowa District 1 United States House of Representatives. Welcome to you all, and thank you for being here.
Thank you.
Morning, Bill.
Todd, if we could begin with you, and perhaps you could give us a little bit of background about the recent ruling and the constitutional issues.
Sure. Well, it's a long, complicated statute, the Patient Protection and Affordable Care Act, but to very quickly explain the provisions that the Supreme Court was looking at, you kind of think about the statute moving in 3 steps toward one goal, and the goal was to come as close to universal coverage as they could, even if they were going to fall short at the end. They wanted to come as close as they could to universal coverage for health care. And so if you think of the first step as saying to the insurance companies, we're going to, under law now, you can't deny coverage to someone because they're sick or they have a pre-existing condition. You have to take them. And when you do take them, you can't charge them sky-high rates for their policies. You've got to charge them about the same as what you charge other people in that region. Okay? Now when you think of, that's the first step. Now that gives people an incentive to hold off on buying insurance until they're sick because they know the insurance company can't say no. And in the meantime, it's going to put a huge financial burden on the insurance companies. So the second step, which leads to the first thing that would later be challenged at the Supreme Court, was what came to be known as the individual mandate, saying to people, we're not going to let you wait until you are sick to go buy your policy. Most people who are financially able to do so, and the statute defines parameters for who is and is not able to afford a policy in Congress's eyes, you have to go now buy a policy that will provide at least a minimal level of coverage. Now that's the second step. And the third step is there's still going to be people who, for financial reasons, can't afford to buy a policy. And the way Congress decided to address that was through a very significant expansion of Medicaid. And while the federal government is going to pick up most of the cost, ultimately 90% over the long run, the states are still going to have to chip in a lot of money too. And so the 2 provisions that were being challenged at the court were what I'm describing here as the second and third steps, that individual mandate, an argument that that exceeded Congress's power, and also that expansion of the Medicaid program, that too exceeded Congress's power. And I don't know whether you want to, how much into detail you want to get in the ruling, but the bottom line, kind of headline news, as we now all know, is the individual mandate was upheld, surprisingly under the taxing power, not the commerce power. And the heart of the Medicaid expansion was upheld, but states have greater flexibility to decline to participate than Congress intended them to have at the outset. And there's a little quirk there, which I can explain if we have time and if you're interested.
Sure. So, Ben, I guess I'll jump over to you on this. There was definitely some very diverse opinions about the issue, both before and since. And I guess I want to dig into a little bit where now we seem to think that there's an extra tax that somehow has come into play. Would you mind addressing that a bit?
Yeah, well, I think as Todd mentioned, the fact that it was ruled upon the taxing power really threw, I think, a curveball to most folks out there. They were anticipating a ruling to come from the Commerce Clause for the power of the federal government to rule into the interstate commerce. And for that now to come to essentially the third default argument by the federal government that it was a tax, I think it sent people up in arms because, we heard it sold to the American people by the presidency and by other folks in office that, you know, quote, it's not a tax. It was sold all the way along that it's not a tax, and now that it is, has really raised some eyebrows with it. But I think the concerning part is if you take that to its logical conclusion, then so long as the federal government is taxing anything, whether that's action or in this case inaction for not signing up to take health insurance, then there truly is no limits on the federal government's authority anymore if you take that to its logical end. And I can tell you out on the campaign trail, regardless whether it's the issues on the left or the right or independent voters, this is still a hot topic and people want to discuss it. And you know, I always remind people, regardless of the outcome of the policy, there was a paragraph in Justice Roberts' opinion where he says, you know, ultimately it's not the job of the Supreme Court to protect the people from their own political consequences. And what he's saying by that is, you know, the American people elected these folks and this is the policy they put forward. And as a result of that, if they are upset with this, well, then they know what to do. And I think that's Chief Justice Roberts' opinion in saying, okay, American people, it's now on you. It's your turn to have your voice heard.
Peters, that's I guess as a matter of public policy, does that kind of conversation piece make sense? Does that seem like that's a direction where we would take that natural conclusion?
Well, our job at the University Public Policy Center is to study and try to inform policymakers, not advocate for policy.
Sure.
When I take a step back from where this all started, I mean, the whole process really started because we have, you can argue about the exact number, but a large number of people who are uninsured in the United States, roughly 50 million if you believe the general number that is used. And you've had people particularly who were in the individual and small business market who have been trying to purchase insurance, you know, through the regular process, who have had problems when they've had pre-existing conditions, when they've had annual maximums that have changed, that somebody gets sick, they're affected. And so, you know, this was originally put in place to try to help contain those things and make it a little bit more of a predictable market. The individual mandates started coming in because the insurance companies were saying we're only going to go along and get rid of pre-existing conditions and annual maximums, those things, if you bring all of the uninsured in and not what they call moral hazard in an insurance perspective, to say that we're going to allow those people who are sick and need care to buy in and not have the rest of them. So it was really, again, the insurance companies that were saying, okay, we'll go along if you bring all these people together. Then you start getting into, well, how are you going to finance it and who's left? And the individual mandate will really only affect about 6% of the population, according to the Urban Institute statistics. But I think the thing that gets to people is the idea that the government's telling you that you have to do something, and people don't like to be mandated to do things. Then you start getting into the cost issue. You know, we're spending close to $3 trillion a year on healthcare costs in the United States, and then what do we do to try to hold those costs down? And then you can kind of sort of get into the argument, are there enough provisions in here to help do that? And those are actually going to think, the ones that I think could be most successful long term are much more subtle and aren't the things that you often hear about, and we can talk about that. But I also don't think there was any way that they were going to be able to get more provisions and stricter types of cost containment into this. It was, you know, enough just to even get this through.
Right, right. And I guess one of the questions that keeps popping up in my mind as I'm working through this issue and seeing how it gets thrown around and used as a weapon so often is, when it's all said and done, is it really going to address the issue at hand? Is it really going to keep healthcare costs down? You know, and is it going to make it so healthcare is available to the general population? Is that something that...
Well, I can tell you, talking with Iowans, you know, all across the state, the concern is, did it really address the cost curve? And, you know, the question's always brought up, you know, the federal government's involvement in any aspect of any sector of the economy, is that an efficient use of the federal government? And what can we point as an example that the federal government's involvement in something has actually driven the cost down? And I think what we're seeing here is the federal government intertwining itself into the healthcare sector. And I can talk also as a small business owner that I think the right sometimes loses when they say just repeal this aspect, because then we're just back to square one, and as a small business owner we're dealing with 18 to 20% premium increases every single year, and that's not the answer either. The status quo isn't working. So I think really what people are left with is what is the choice, how we're going to control costs? Because there's really two options. There's going to be the government situation where we have now with the Independent Payment Advisory Board, that is the board of bureaucrats that are going to determine our cost, quantity, and quality of health care. Or the alternative is to empower individuals to choose plans that best fits their needs. And I think people out there, at least across Iowa, they would rather have their say in it. If their ability to go out and choose the health insurance plan that best fits their needs, and also to reward companies that provide low-cost, affordable health care, and also to punish those companies that don't provide that type of health insurance to them, then we have individuals. We've powered the individual to choose the plan that best fits their needs. And I think that's what, when we're talking about the concern with the individual mandate, is being told by the federal government that you have to purchase something, as opposed to allowing individuals to have the power of choice.
So Todd, I want to make sure I understand it from a constitutional standpoint. The individual mandate is or is not something that our Constitution would allow?
It depends on how you understand it. Okay? According to 5 justices of the court, Justice Roberts, a Republican presidential appointee, and then the 4 members appointed by Democratic presidents. According to those 5 justices, if you look at the mandate as a law that says the law requires you to go buy insurance, and if you don't, we're going to penalize you, you can't do that. But if instead you say, we're just letting you know, for those of you who don't, we'd like you to buy insurance. If you don't, that's fine. It's not a violation of the law per se. We're not going to penalize you. But you're, in choosing not to buy insurance, we are now going to impose this additional tax on you. If you look at it that way, then the Constitution does allow it. Now, that's a pretty subtle distinction. And if you're stepping back and looking at the larger picture about what should the federal government be allowed to do, that distinction is probably not going to be very satisfying for you. But if you're going to look at it in a more kind of granular, looking at each clause of the Constitution by itself, then you might or might not find that persuasive. But it's taking it from the point of view of just a tax on someone's choice not to engage in a given activity, that is, the activity of going out and buying a policy. You're not required to do that. The law doesn't demand that you do it. But if you don't, we're going to tax you. That's fine.
So the thing that's kind of pulling at me here a little bit is if we can tax as a penalty to someone that can't already afford health care. I mean, that's kind of the premise of the law, correct me if I'm wrong, but it's going to the folks that are choosing not to purchase health care, and it's making a penalty for those folks. Is that?
Well, Pete and Ben both can speak much better than I to whether Congress drew the law in the right place, but Congress purported to say those who really can't afford it, you're not required to pay. We're not going to impose the tax on you. So, for example, if you don't make enough money to even have to file a federal income tax return, then you're not subject to this tax. Now, whether that's the right place to draw the line and how much money a household has to be drawn in before we can say you can afford insurance, I don't know.
Well, I think there is a misperception out there that somehow this is going to be a burden on those least able to pay, which actually it's the opposite. Because the way the law is structured, you're going to have, assuming there is the Medicaid expansion, which right now Governor Branstad has said that Iowa is going to forego. But the way it's designed is that everyone up to 133% of poverty level will be eligible to be in the Medicaid program. Because right now you have to both be poor and you have to be what's called categorically eligible, meaning you have to be a child, you have to be a pregnant mom, you have to fall in a particular category. So low-income single adults in particular are the ones that right now fall into that, and 80% of the people who are uninsured are actually working people and their families. So there's this perception also that if you work, you're going to have insurance, and if you don't work and you're lazy, you're not going to have it. What really ends up happening, it depends on where you work. You can be doing the exact same job at 2 different companies, and because we have a lot of employer-based insurance in the United States, obviously, you can be working and doing the exact same job at this company and get your benefit, and this one you can't. And many of those people are going to be in lower wage jobs, and right now, an average family policy to purchase in the United States is about $15,000. And so there's no possible way that they can then go out and purchase a family policy if you're a low-wage employee. So the lower-wage people, again, would be first in that Medicaid expansion, And then when they move into what's called the health insurance exchanges. And the idea there is it's like a health insurance marketplace, almost like Expedia or some sort of an online product like that, where you would then choose between different levels. So you have some choice in terms of how comprehensive the coverage is. And there's going to be, they call it a bronze, silver, gold, and platinum level of benefits. And so that they're all going to be covering certain things like preventive care, but your co-payment will be different depending on what those are. And so then people from 133 to 200, it's a little unclear. There's some different options. And from 200 to 400%, you'll get subsidized to be able to purchase private insurance through this health insurance exchange. And then above 400% of poverty, those were the people who are going to be relatively on their own, but very few of them are actually uninsured.
And I think the real concern is, I think there's a study out there now that says it's possible that 75% of the individual mandate penalties are going to fall on individuals making less than $60,000 a year or families making less than $120,000 a year. 75% of those penalties, those are the folks that are going to pay that. And I think the real concern ultimately is what we have just put in place is there is no personal conscience when it comes to consuming or utilization of health care insurance or health care services, because now we have health care just delivered from the federal government. And I use the example of my family. You know, we had to switch because of the increased premium increases every year. We had to switch from a standard health insurance plan to a high deductible HSA. And the very first time that we switched to that, my daughter falls and breaks her arm. And the point being is that because now we had an HSA, health savings account, my wife was scouring that statement that came in from the hospital there because she wanted to know, what is this charge for? What is this charge for? What is that charge for? And what we did is we ultimately, because of the change in dynamics in which the marketplace was taking place because we had an HSA now, we were the first ones to write the check for the cost of those services. We became much more cost conscious of the services we were using. And I think what we have put now is that the insurance will come to us and we'll just assume that we hand over our insurance card. And I think the dynamics in which the consumer is purchasing health insurance still hasn't changed. And as a result, the utilization of health services is going to continue to rise, and that will ultimately increase costs for all of us.
I beg to differ, just because most of our insurance is not going to change. For everyone that has employer-based insurance right now, again, there's going to be some change on the margins, but for the most part, this law is not designed to change the employer-based insurance. There's going to be some businesses that it's going to be beneficial for the business to actually stop providing insurance and more beneficial for the workers. But for the most part right now, employers are not providing health insurance because they have to. We don't have an employer mandate in the United States. They're doing it to recruit and retain employees. And that's not going to change after this. Then the majority of people who are actually going to be gaining insurance coverage are gaining private insurance, not government insurance. Of the estimated 32 million people who are going to gain coverage of the 50 million uninsured, the majority of them are going to be purchasing private, well-marked type products through the health insurance exchange, other than those people up to 133% of poverty who will then, those singles who will then be eligible for Medicaid. And so it isn't clear actually how much of that, and the incentives that you're talking about are not going to change. There's still going to be HSA products. There will still be a variety of things. I was at a session this morning that the Quarter Business Journal put on here in Cedar Rapids, and there were some people in benefits and some others, and it was very interesting. You know, there will be some shifting, but it isn't clear that there's going to be a dynamic change in a lot of those.
I want to make sure we kind of cover one of the points that was brought up, though. I have noticed, just in my own visits to a doctor or to the hospital, that often I don't necessarily see an itemized bill that comes home. It's just paid. And I celebrate that fact. I have insurance and it's great, it's all taken care of. But I kind of lose that accountability piece where, one, I'm not necessarily looking at it and say, did I really get 4 of that? And also, you know, but there's still that peace of mind. So, you know, I understand that. But when we take that piece of the bill actually sitting in front of me and having to go through and itemize and say, yes, I'm paying that, or no, I'm not, the reasonableness of the costs, the other factors that go in there, it seems that we lose a lot of control when that happens.
That was one of the aspects that I was just referring to, is that when the individual consumer is not cost conscious, there's no incentive for them to drive down costs from the provider. And I think, and until we empower every American out there to be cost conscious and be concerned about the healthcare services they're utilizing, I think there's going to be no incentive to do anything but to hand over your insurance card and assuming that it gets paid at the end of the day. But I did want to address one of the points by Peter, is that I think one aspect from a tax policy that's a concern is that the employer, when he provides health insurance for his employee, he gets to deduct that expense. And I think we are essentially having a prejudice against an individual out there that wants to go out and purchase health insurance on their own, because they don't get that same tax treatment. And I think if we were to eliminate that prejudicial tax treatment against the individual, empower that individual to choose the plan that best fits their needs, and then they get that same tax treatment, then all of a sudden that health insurance policy is personal to them and not necessarily connected with the employer. And I think we can then get around some portability issues that we were concerned about, which may have been one of the reasons that we had the Affordable Care Act in the beginning, is individuals to take that health insurance with them.
I think that shows, our conversation shows just how hard it is to make good health policy and why this is such a tough problem. When Ben talks about the issue of incentives, I hear what he's saying, and what he's describing is part of a pretty complex web of incentives. On the one hand, someone who could afford to, whose finances are personally on the line, and you're talking about that itemized bill coming in. It makes good sense to me. I'm not a policy expert, but just as a listener listening in on the conversation, it makes good sense. We want that person to be incentivized to scrutinize the bill, to speak up if it looks like there's some unnecessary charges or some charges for services that weren't actually performed. Then we compare the person who has plenty to pay, but knows that if they go to the emergency room for a non-emergency need, if they wait in line long enough, they'll get their care. And somehow we want to write the law that puts an incentive on them to take some responsibility for their payment. And then we've got people who, they're getting the statement, and far from just trying to look through it to see what they're willing to pay and what they're not, they're thinking, we don't have the money. You know, we just got a $5,000 bill. We don't have the money. And if we go too far in putting in emphasizing individual responsibility, then we don't care for those folks who can't pay. And I have no idea where the right answer is. I'd be stunned if the current statute got it right in all these respects. I'd be amazed. Surely we're at the early part of a process that's going to, I'm in my 40s. I expect to retire with this debate still going on.
Absolutely.
And I think you're absolutely right. And that gets back to kind of the earlier question is, does this act really do much of anything? I mean, we're spending a huge amount of time debating it in the public light. It's constantly on the news. We're using all kinds of language to assault each other with it. But yet, are we really solving anything? Are the issues being addressed that really need to be addressed? Are we keeping health care affordable? Are we addressing a situation where somebody really can't afford it? I think, my personal feeling on it is that we do have somewhat of an obligation to take care of those that truly can't take care of some of their basic needs. And health care, to some extent, I think is that.
Right. Well, the interesting thing about the Medicaid expansion piece, if Iowa or any other state opts out of that expansion, you could end up with a situation of the people under 100% of poverty who will be the only ones who will basically be locked out of getting subsidized health insurance, because they are, as the law is currently written, are not eligible for that subsidy if they go and purchase it out of the health insurance exchange, and yet without a Medicaid expansion they could be without. So I think, again, you could argue if this is the right way to do it or not, as Todd is alluding to. but it is an attempt to look at the financial access piece of this, and by providing people with insurance coverage in various types for those people who are uninsured. You've got a lot of other access issues, provider availability, provider type in an area, whether someone will take someone's type of insurance. Someone might have Medicaid coverage, but yet they can't find a provider that will accept it. Then you start getting into delivery system issues. And those are where we're talking about the individual responsibility, and there's a lot of people that are placing more and more emphasis on that. But what they're looking to do to bend the cost curve, as they say, with this is looking at it being driven from the provider side. And these are pieces of the law that isn't being talked about very much and gets sort of complicated and mundane to some, but there's something called accountable care organizations, which is going to be the delivery system actually coming together, and they're going to be rewarded for reducing costs. So in Iowa, for example, we've got what's called a Pioneer Medicare ACO that's formed in the Fort Dodge area. And so the way that's going to work for people that are in Medicare in that area, the healthcare providers have gotten together, formed this accountable care organization, and they will be put at some risk, financial risk over time, so that if they can demonstrate that they have reduced cost by eliminating redundant tests, re-hospital admissions, emergency department use, things like that, they will actually be rewarded for some of those things, because really most of our healthcare costs are not under the control of the individual. Routine types of things are, but the people that have cancer, the people that have everything else is really being driven by the provider side. And so they're the ones that control what tests get done. People don't know, do I need a second CAT scan? Do I need an MRI? Do I need this? Do I need that? They're going to trust what their doctor says, and should. And so they're looking to actually control it in this way. And we can talk more about that if you want to.
Ben, I want to just kind of delve a little bit into this from a person that might be in Washington standpoint. I don't want to put you too much on the spot, but I'm going to a little bit anyway. It seems that the act was put into place, not necessarily bipartisan, but there was both parties that were voting on it. Now all of a sudden we want to throw it all out or keep it all. Often when I see an act go into place, I'm thinking, well, let's go for it, and then let's tweak it out. The things that aren't working quite right, let's fix those a little bit. But here it just seems like we're just so combative about it. Is there something that we can do to maybe kind of ease our minds a little bit, that we're going to see some progress?
Well, the short answer is no. I don't think there's anything that can ease our mind about it. There are strong opinions out there, and I think what Todd mentioned at the very beginning is the idea that the mandate, you're being told that you have to purchase this or else you're going to pay a tax. And as I mentioned at the beginning as well, that wasn't how it was sold to the American people. That President Obama stood up and said, this is not a tax. And now for the Supreme Court to rule that it is, regardless of the outcome, it was sold in a different manner. And I think that's what doesn't sit quite well with people out there. But I think you had mentioned a little bit ago is, does it really impact us? And the answer is, unfortunately, yes. I mean, I think the cost curve is going to continue to go up. They estimate $500 per year increased cost for younger Americans to buy their own individual insurance. The cost tag of this entire piece of legislation, I don't know that there's anyone in the country that knows the true cost of it, but there's estimates that it's over $12,000 per taxpayer over the next 10 years for this piece of legislation. And the impact I think we're going to see unfold in a 2,700-page bill that no one really has read, no one really understands the implications of it. That is what still upsets people across America, and especially in Iowa. And I think there's still an opportunity to have an intelligent debate about it and discuss what we can do. But ultimately, we're either going to empower the federal government to be more involved in health insurance, or we're going to empower individuals to make those decisions. And I think Iowans are ready to really empower individuals, because they're the ones that, it's their health, it's their concern, because it affects them so personally.
Yeah, I wish I could be more encouraged. I really do. It just seems that we're pushing so hard to find divisive ways, so that we're not finding common ground. And I would just really love to see us work hard to find common ground. And I understand that there's some things that we feel that we were misled about, and that we have to do a little better. So I think we're about out of time today. So thank you for joining us for Ethical Perspectives on the News.